Mike, good morning. It's good to have you today.
Thank
How
you,
about
Oron, and thanks for having me this morning.
absolutely. I thought about maybe take a couple of minutes to maybe tell our audience about yourself and about Stellar. They can do the same for Vim. And we can take it from there.
Sure. I find sometimes that I have an interesting background for being a co-founder CEO in our space, in that I was an investor for 15 years at a firm called Apex Partners, where I spend all my time investing in healthcare, private equity, and then about 5 years ago now had a little bit of an existential crisis, decided I was not doing enough to change this thing we call healthcare in the U.S., and so gave that up and jumped on in.
Yeah, and Grizzly, it's a super interesting background. I think being able to see horizontally what's going on in the industry and identify the opportunities is something that I think gives you a really interesting advantage. And Stellar is definitely a very exciting company. It's one of our early partners. And as a way of introduction, I'm the CEO at Vim and the co-founder at Vim. Started 8 years ago, and we haven't always been focused on purely interoperability and solving that last mile point of care integration point, but we have seen that this is a pretty common pain point for many companies who innovate in healthcare, like Stellar. And if we can solve that one single point of friction and get applications and data and workflows integrated more simply and faster and with more flexibility, we could make something people need. So that's kind of what led us to this. And prior to Vim, I was in telecommunication, gaming, and just spent time in the military, like many other folks from Israel. So it's really great having you today, man. I'm really excited about our partnership. I think maybe telling us a little bit more about how you guys started Stellar, what led to the specific idea, kind of the underlying, the first principles kind of led you to build this amazing company. Maybe where do you see the kind of the next couple of years going for you guys, very high level?
Yeah, thanks, Oron. And I will say that I do think that interoperability is probably one of the biggest drivers of the next wave of healthcare here. I think if you ask people about ideas in this entire space 20 years ago, 10 years ago, that interoperability layer didn't really exist, and that really held things back. As an investor, I saw a lot of that. We used to own a company called TriZetto, which is the claim system. We also put together a clearinghouse called Gateway EDI with it, and it still had all sorts of issues connecting just two simple things, let alone lots of different parts of the ecosystem. So I think what you guys do at Vim is super important to really enabling all of this value-based care movement that we will have to have. In terms of how Stellar got started, it's kind of an interesting story. I did not come up with the idea. I can't take credit for it. Me and my co-founders, we observed groups of doctors, MSOs, managed service organizations that took risk. And what they did was they decided that if you reward the doctors based on the proportion of action and work that went into value-based care instead of fee-for-service, so instead of just seeing patients, seeing the right patients, doing the right things for those patients, if you shared the bounty, the rewards that way, doctors will do more of it. Doctors are smart people. They will figure out how to do more of those right things if they're rewarded for it. And so we said, wow, that makes total sense. It's super simple. Let's actually change the reward system to match the value-based care outcomes. And we said we want to build some technology for that instead of maybe tracking it on spreadsheets. And that's kind of how we got started and away we went.
It's super interesting. Do you think there was any change that enabled that, or you think the writing was all kind of on the wall the whole time, and it was like obvious that something that needs to be like why haven't anyone else did it before you guys did it? Or have you seen, have you observed other type of behavior that told you, people do try to do some of those things, but nobody really scaled that in a systematic way?
Yeah, I'll tell you, I think it comes from actually the payer-provider divide. I think if you're a payer, you sit somewhat in an ivory tower. And the truth is we're all healthcare execs a little guilty of this, in which for us, a lot of these open gaps are a number in a spreadsheet, right? It's an open gap or a closed gap, 1 or a 0. There's 4,300 gaps open, and 6,200 gaps closed. It's something along those lines, which is, by the way, correct. It's data and analytics that I just cited, but it kind of, you view that from the lens of this high up tower, top down, and then you have the providers on the other side who are like, you don't see that I have 40 patients coming in every day, that I'm running from visit to visit just to keep my practice going and make my ends meet. And yet you want me to also do these extra things to close out those gaps that are pretty important. So I think the problem you have is you're kind of not seeing, either you take this payer perspective, which is, look, I reward you when you achieve all these gap closures. Why don't you just do it and earn that bonus? And then there's like the day-to-day on the ground, people who have to follow through, see patients all the time. And I think the issue is that how they get paid on the ground is very different from the reward system today. So we thought about bringing those two closer together. And the simple concept, right, is if you ever talk to a physician, and I have to say that my wife's a physician and I know a lot of physicians, but they get paid on something called RVUs, relative value units. It's how our physician fee schedule is set up. And that's part of the issue, right? Is that we pay for more volume of service, and it makes sense though. There's nothing wrong with that. If you were to hire an accountant or a lawyer, you pay on the hours that they served you, right? So it makes total sense that we have the construct that way. But as you change to a different outcome that you want, then you got to adapt that payment system towards that. And so that's what we decided is the real issue is we want to translate. We know what the payers want, and we also know what the providers can do. Let's pay the same way they're used to already was really the big kind of insight in there.
Yeah, no, this sounds like hitting in a huge industry issue. From a Vim standpoint, we're trying to tackle similar things between payers and providers that more relate to the way that payers and providers share data. I think for us, we also see that the current way that providers and payers interact is pretty stale, in the sense that there is a contract that you figure it out. There is less enablement, and so on the provider side, I think that's what we're seeing, very little adoption of, I would say, more complex value arrangements. I think on one end, payers are afraid of completely delegating something away, that they still want to, be a payer and underwrite an outcome. And on the other hand, providers are finding it really difficult to deal with anything that is not full delegation. And even if they're taking full delegation of risk, they still need enablement tools to take things. Quick forward here to what we're trying to do together at Stellar and Vim. So Stellar is one of our first platform partners. We've been really focused up until this point of enabling payers and payviders and how they interact with their providers. I think Stellar is, for me personally, it's symbolizing the beginning of something bigger in healthcare, something where you take something very specific area of complexity, and you're delegating it in its entirety to a third party who can manage it better than you. I'm talking about payers or payviders or aggregators in that sense. And us at Vim wanting to enable this with a lot of rich functionality and sophistication that maybe other larger players may not be able to take advantage of. So I'm pretty excited about what you guys could do. It kind of reminds me of things like Uber or other applications that only been enabled once you had smartphones. Obviously, you guys can operate without Vim. You have standalone applications that can sit in the clinic, and you are doing this today. But I think with our technology, you might be able to get closer to the physicians, get closer to the workflow, be there when it matters at the point of care. I am excited about what you guys could do for the future of value-based healthcare. And while I know that there was a lot of focus on quality and diagnosed gaps and referrals, but where do you see kind of the future? I would say the near future. If where are you guys going and where you guys can also impact the practice. And the second question would be, how do we work together to simplify the clinic burden and the provider overhead while doing that and not making it more complex for them? So just hearing your thoughts on those two questions.
Yeah, maybe I'll take the questions, second one first and in reverse. But I think the reason I get so excited about the partnership is exactly what you said around making it easy for the clinicians and their staff in their workflows. The way we think about a lot of things, just in terms of a framework at Stellar, is you kind of have two choices of a value prop for that doer of work. You can either choose, right? And why does anyone do anything? Either you pay a lot of money. So if I paid you $1,000 to do something tomorrow, you might just do it. If I say, hey, go to the gym tomorrow, I'll pay you $1,000. If I pay you enough money, you'll do it, right? And that's value for yourself. If I also make it as easy as possible for you, then I can also pay less and you'll still want to do it. Say the shoes, your shoes are already tied for you and you're already transported magically into the gym, you might just start working out, right? So the key is, how can you make it as easy as possible while paying as much value as possible? That makes that doctor or that staff member feel very rewarded for doing these things in general. And so where I see Vim fitting in particular is making it that easy. It's making it so that it's right in front of the doctor at the exact right time. A lot of times we see a lot of payers who hand over these, gaps in care reports, et cetera. We call it tossing it over the wall, right? Because you kind of like hand it off to the provider, like, here you go, please make some sense of this and do something about it. There's nothing about here's how it fits into your workflow. There's nothing about when that patient is in front of you. There's nothing about, this is the exact moment in which, like an Uber driver, they can pick you up, or that doctor can actually talk to you as a patient about getting that mammogram done. So it's all these right moments that I think really matter. And I think that's where Vim really brings an advantage. And so our goal is, let's make it as easy as possible with Vim, lowering that bar even more than that we had it, while we continue to bring even more rewards in. That's going to make the providers and their staff really happy and want to keep doing more of this.
Yeah, it's super helpful. And for the second question on your view on, and actually want to add something to this. So, we have seen recent CMS regulations around, or potentially CMS regulations coming around risk adjustment and what's going to happen in 2024. Our margins going to get squeezed. We don't know what the future is really holding at this point. You guys likely understand this a little bit better than us. But at the same time, I think there's going to be much more emphasis on quality and area where I think Stellar can make a huge difference. So maybe you can talk a little bit about how you guys think about quality and what's coming next.
Yeah, maybe first, just from my investor hat, and I've always carried this, I always view it as there's three levers in value-based care. There's risk adjustment, which we should not underestimate the importance of risk adjustment. I have lessons from the 90s in which people put Medicare Advantage plans on the fourth floor of a walk-up without risk adjustment, because if you could walk up those stairs, you were a healthy patient that I wanted to keep. So there are issues when you don't have risk adjustment in itself. Second is quality as a lever, right? We got to make sure we maintain quality while also driving lower costs. And the third one is total cost of care. All three buckets are very important to all this, and you have to treat it holistically. If you only think about one thing or the other, I think you quickly can go down, I think, some of these wrong paths that maybe some folks have maybe taken a little too far. In terms of quality, I think that's definitely the future of where things go, along with total cost of care. I'm really excited, Oron, for us to move towards, we both do referrals, smart referrals, let's call it, in terms of lower, better site value, lower cost of care, but high quality values. I always say, take an MRI, a freestanding MRI is significantly cheaper than the large hospital system one, right? And there's no reason. The machine's literally the same GE or Siemens machine. It's sometimes even the same radiologist reading them. So there's no good reason why that is, except for hospital outpatient fee schedules that we have as differences. So I think we need to be pushing more into those other levers, whether it's quality or total cost of care in general. I don't want to minimize too much on the risk adjustment, in that one thing I think we both do that's really important is that the risk adjustment is always prospective in nature, right? And what that means is, if it's prospective, you did something for that patient. You treated the patient differently and took care of whatever that thing was. Say you have COPD, you really might actually change out their air conditioner. You might get them a pulmonary function test. Those things may have changed the trajectory of that patient. So when you do risk adjustment properly, it's actually about addressing the condition up front And I think one thing I'm proud of, and we would not have partnered with you if this weren't the case, is that we're always thinking about how to get that doctor and that clinician to do that up front so you actually help that patient. That ties right to quality. It ties right to total cost of care ultimately too, because it's that interaction with that doctor that influences all three of those things at the same time. And again, that's where our partnership can be really powerful, because now you're getting the doctor, you're making it easy for them to want to do any of those three things or all three at the same time when they see the patient.
Yeah, no, this is great. I very much agree, and I very much agree with what you said about risk adjustment. I think you can't have value-based healthcare without risk adjustment, so it's definitely here to stay. I think companies like Stellar and Vim could help reduce a lot of the overhead associated with the operation of risk adjustment. As today you have a lot of different people touching the same food chain that leads to that outcome, and if you can automate a lot of that, I think it'll be even easier to operationalize. So I'm excited about where we can take this. There's a lot of technology can touch it today, especially because both of us are kind of operating in a multi-payer environment. So I think that can really solve that problem. This is great.
Oron, just on that comment, I've definitely met groups where they have 300, 400 people in their coding billing department in the back office. And you're like, is that necessary? And does that really help the whole situation, right? And what they're doing is some of the stuff that's less positive in terms of going to search for codes, rather than, I think what in the end CMS cares about, and I have to believe this is how they think about it, is you care that their primary care doc, that doctor that treats you, knows about it, right? Like, what good is knowing the result of a mammogram as you have breast cancer if your doctor doesn't say, okay, now that I know that, let's get you surgically to remove that early stage rather than later, right? And so it's all about upfront, that doctor knowing. In some cases, I actually could care less if we didn't get the code properly done, but if the doctor knew it and did something about it, that's actually the most important part. So we sometimes use that as our North Star of, did you get the doctor to pay attention and do something? That's the most important part of it.
And that ties back to your prospective approach to risk adjustment and why it can tie to quality really nicely, and get a 2-4. This is great, Mike. I really enjoyed our conversation. I think that it really distills kind of what we both came to do together here, and I think that's very complimentary. And I'm excited to continue our partnership this year. Thanks for joining me today.
Thanks for having me.